for those who don't know me, my name is Michelle. I'm one of the third year EMIMs, and I'm doing our small talks in renal. So I think we're going to do part two of contrast or no contrast. I think Kyle had given a talk about this before, but I'm going to be a little bit more focused on this top and speak about guidelines currently. So we have three patients that come in. So we have someone with ESRD, AFib with adrenal pain, your renal transplant patients that are unable to tolerate PO, and they are retching and they've had prior abdominal surgeries in the past, as well as a CKD4 patient with rectal bleeding. So how would anyone in the audience kind of tackle these patients that would likely need some sort of CT scan?
I would scan them mostly.
Would you guys change your practice in terms of scanning anyone? These are all stable patients. So would you wait for the creatinine that all our radiologists want, or would you want to do something different beforehand in preparation and anticipation of getting a scan?
ESRD patient would probably just go ahead and scan, and then they can get dialysis whenever. CKD4 patient I'd be a little more careful with. They're probably volume down from the vomiting diarrhea, so I'd prehydrate if I had to get a scan. Then I'd get a scan after hydration. And I forgot what the renal transplant. I would probably wait unless the scan's really urgent. But I would probably wait for the creatinine and maybe talk to the transplant service, especially if it was a recent transplant.
I think I would just scan them without contrast and not wait for the creatinine at all.
Okay. Okay. So I'm just going to go through the current American College of Radiology as well as the National Kidney Foundation's consensus statements that came out in 2020. So in terms of definitions, when we talk about contrast-induced nephropathy, that is no longer the definition that currently stands. They've transitioned to the definitions of contrast-associated AKI, contrast-induced AKI, and there's general terminology for AKI, which is, in their opinion, 48 hours after contrast administration in these contrast-induced AKIs, as well as CKDs and GFRs. So going through these definitions, an AKI generally is a creatinine that is an increase of at least 0.3 or about a certain times more than their current baseline creatinine. Of course, we don't always have baseline creatinines for everyone, so it's hard to kind of discern what's an AKI or not. But this is the general definition of an AKI from their standpoint, from KDIGO. This is also in terms of kind of generalizing how they risk stratify patients. They kind of go through the GFRs and kind of call it either CKD 1 to 5. So these are the general number, but the number that you typically are more concerned about would be a CKD 3B, below a CKD 3B. So based on observational studies that they have found, with at least contrast-associated AKI with every GFR drop. There's an increased chance of developing a CA AKI. So with a normal GFR or like a CKD approximately like 2, 3 to above, there's approximately a 5% association based on observational studies, 10% for anything with the GFR between 45 to 59, and it kind of goes up to approximately a 30% chance if you're CKD4 and below. Based on other observational studies, at least for contrast-induced AKI, it's pretty much near zero. For anything for GFR greater than 45, but with any GFR less than 30, they're saying it's between 0 to 17%. And this number ranges because these are all based on observational studies and not necessarily randomized control trials. So in terms of talking about the guidelines, they kind of go through things and talk and discuss things like, do we need a screen for these patients in terms of creatinine and kidney function? Do we need to do prophylaxis? They did talk about like generally if you have essentially a single functioning kidney, if you're on dialysis or if you're CKD 4 or 5, not on dialysis. So in terms of discussing these recommendations, we'll first go through screening. So they generally state that for the people that you have concerns for for the possibility of CKD 4 or 5 or like basically abnormal kidney functions, you should probably draw blood. So these include people who have uncontrolled hypertension, if they're older, if they had known prior kidney disease, if they are diabetic. They didn't really mention much about they did briefly mention metformin, but obviously we're not going to talk about metformin while here in the ED context, as well as hyperperfusion. So people who are hypotensive, who have basically like volume overload that's maybe inducing this AKI or anything like that, anything like hypovolemia. So that's the recommendations from ACR and KF standpoint. The next thing to talk about is CKD 4 or 5 not on dialysis. Based on the current studies that they have found, they note that there is an increased risk of developing CI AKI in these patients just because their kidneys cannot clear this contrast as quickly. However, again, these are observational studies, and based on observational studies, the number needed to harm for these patients go from 6 to infinity. So again, no study or randomized control study has been done to see if there's actually CI AKI that's been induced, or sometimes they call it post-contrast AKI. In any situation, even in the guidelines, they clearly delineate, do not withhold if it's kind of a life-threatening diagnosis and you need to do any sort of intervention. So from, at least from the ED standpoint, definitely do not wait for the creatinine if this is something that's going to change management or kind of adjust and help save a patient's life. In terms of recommendations for transplant or solitary kidneys, they are treating the single solitary kidney or like effectively a single functioning kidney as the same based on the current GFR. So if their GFR is kind of within the range of CKD4, basically 30 and below, obviously just be careful in this situation and have consideration for AKI. And previously in the 2015 guidelines, there was a recommendation to maybe hold off the contrast, but in a study in 2016, published in the American Journal of Radiology, they had done a contrast study, and specifically an intraarterial contrast, where they found that patients generally with normal functioning kidneys, even in the setting of a transplant, they did not really develop CI AKI, but for those that did end up developing CI AKI, they actually tended to be hospitalized patients. So there's a lot of confounding factors in this situation where they are saying maybe there's nephrotoxic drug administration, other than the contrast load. They had reasons to be admitted, and they had more comorbidities. So based on this study, the 2020 guidelines had changed and said recommendations for basically normal. Just proceed as CKD 4 below, or just proceed based on their GFR. For patients on hemodialysis, the recommendations was a little different in the sense that if this patient does make urine, approximately like 100 milliliters of urine a day, maybe consider holding off contrast in the case there's any sort of renal function that they want to be preserved. But in terms of dialysis schedule, sometimes we do call renal to maybe dialyze a little earlier. There's actually no recommendations to change dialysis schedules. There's no benefit, and there's more costs associated with it. But the main recommendations that I really wanted to go through would be prophylaxis. So there's generally recommendations for prophylaxis in this guideline where they had recommended it for people who you have high suspicion for AKI or CKD, basically GFR of 30 or less. Um, so they go through talking about stuff like oral versus IV, and they did studies based on different types of fluids for that. Currently, there's no specific guidelines for how much fluid to administer based on their definition of prophylaxis. But they were saying obviously with a prolonged period of hydration, the less likely they're going to develop things like fluid overload and whatnot, or develop anything like CA-AKI. So we actually have a policy in place right now at Kings County, where the recommendation to prevent PCAKI or like CI-AKI would be to fluid hydrate. And this is their possible protocol where you should give 100 cc's an hour of normal saline 6 to 12 hours before they get contrast, and then 4 to 12 hours afterwards, which is a little crazy from at least from the ED standpoint. I don't think we even do this on the floors. But in terms of discussing evidence for prophylaxis, the prophylaxis thought had come around after we had a decent amount of patients back in 20. There was two studies in 2014, 2015, where there was a possible benefit for fluid hydration in these patients with PCI and STEMIs who had developed CI-AKI. Based on that, they were trying to go through kind of thought process of possibly doing oral hydration versus IV hydration based on a meta-analysis back in 2014. It seems like there was no difference between oral and IV hydration. I don't know if we're going to give a ton of fluids to our patients orally and get a picture for them, but that there is no difference between the two. There was a study back in 2017 in the Lancet called Amazing, and basically based on this randomized phase 3 controlled trial, it was they found that because these patients they wanted to see if fluids actually did help at all. They generally found that there was no benefit. There was no clear difference in terms of preventing the CA-AKI or CI-AKI in these patients, although they did exclude emergency department patients as well as ICU patients. So cannot be generalized to a patient population. Another study that was published back in 2014 was seeing if having sodium bicarb, which would help reduce the fluid load, would actually be beneficial. Based on this study, there's no difference between hydrating with normal saline and sodium bicarb with a lower fluid load. And the same study authors went on to publish this 2020 JAMA trial, which basically showed that ultimately for those patients that ended up developing post-contrast AKI, it's pretty much patients who have many comorbidities, and there's really no difference in terms of no hydration and sodium bicarb. So generally for all of our patients, for the patients that we're referring to, the one with ESRD, a renal transplant, and CKD4, I think I'm just going to go back to our current algorithm that was published, that EMCrit had put up, where if they are critically ill, you can consider getting the GFR, but obviously finding the diagnosis and taking care of anything life-threatening is more important. So, but so you can use contrasts in those situations. But overall, there's really, in terms of guidelines, there's really no good evidence for prophylaxis at all. All our patients generally do have risk factors for CA-AKI as well as contrast-induced AKIs. So a lot of these can be found in the setting of like we do administer nephrotoxic drugs and other things such as fluids that might put them more in overload. So otherwise, ultimately, if anything, get the scan. You can do your dot phrase that you would need to kind of bypass getting things protocoled. Just like to thank the small talks team and